So a person who was not able to breathe, who was on a ventilator, his blood pressures are going down, kidney is failing, he may not be alive to see the next day sunrise. You do a TAVR and next day morning he is sitting in front of you and having his breakfast and actually talking to you. There are very few therapies in whole of medicine which can be as dramatic as this.
I think it's got to a phase where it's like what you call Marvel movies, right? So what we would have never even imagined something like that to happen has happened. And
It's a TAVI, that is transcatheter aortic valve implantation. What it means is that we are artificially putting a valve in the aortic position without doing surgery.
Now what we have almost 10 years data of TAVI, and the patients who have undergone TAVI, they do as good as patients who have undergone surgery.
It has changed the way the cardiology practices has evolved over a period of time for the treatment of aortic stenosis.
Being in an institute like AAG, where the hybrid cath lab is available and 24/7 the resources are available. We have ECMO backup. We have a good team of cardiac surgeons and a very big team of cardiologists. So we're able to deliver very, very good results with our TAVR patients.
When we talk about heart team, do we actually believe in it, or is it only on paper? In AIG, it is actually functions. It is a live entity which functions every day and every time that a TAVR is done.
When we say heart team, that means two interventional cardiologists. They work in sync to make sure that the procedural aspect is smooth.
It is not only just the cardiologist to perform the procedure. So the cardiologist, the cardiac surgeon, the cardiac intensivist, all are involved in decision making.
This is a patient-centric informed decision making, where patient is always in the center.
This is a procedure where from day one you have to be perfect. Nothing less than perfection is going to be agreeable.
so these are all high-risk procedures. If you are doing a TAVI, there is nothing called as a low-risk patient. It is a high-risk patient. That's the reason we do a TAVI.
So all of us sit together one day before the procedure, we discuss what is best and how to do the procedure in that particular patient, and then we perform the procedure in such a way so that we get the best possible results.
And after the TAVR is done, again there is a discussion which is called the debriefing session, where we try to check whether we did according to plan, and if there was a deviation, what are the learnings from the deviation, and what was the reason why we deviated from that particular protocol. And being one of the highest centers, it also has a lot of research and academics which are involved in our TAVR program.
So we at AIG are now doing a lot of data collection, and we're going retrospective and also collecting prospectively what is going on, so that we have a lot of data. We've started doing our publications which is going out.
So recently, a couple of our patients' case reports we published in two very reputed journals. But one is Journal of American College of Cardiology, and another is European Heart Journal. Both have a very high impact factors. We also are working on this hub and spoke model. So many of these patients are referred by the cardiologists, and they themselves also come for the procedure, and not always the referring cardiologist is in the loop.
We had great proctors coming in from all across the world, probably from US, from Australia, from UK. We had so many proctors who actually helped us grow our program, grow ourselves also in confidence, because we started doing a lot of other cases.
And this is something which we want to pass on to others also.
As a proctor, I prep before I go, so that I teach them what I need to tell them. Even before I or anybody of us go there to do a TAVR, we have a plan set up there. We have a call done so that we know exactly what we need. We know what equipment we will need. We will also know the equipment we will need if we need to troubleshoot.
One of the TAVR programs which we conduct is one of the most unique programs in the country. It starts with demonstrating people in an animal model, and you can have a hands-on training of deploying the valve in the heartoid model. So this type of a unique program is one of its kind. And when somebody goes through these type of programs, their entire understanding of doing TAVR changes.
TAVR is here to stay. So it is going to evolve more over a period of time. And both TAVR and SAVR, which is surgical replacement aortic valve, are not competitive to each other. They complement each other.
Because of the AIG's trust factor and the heart team approach has evolved in such a manner that now this place is AIG is seen as a destination place.
We probably are at right now around 350, 400 cases of TAVR that we have done, and we as a team has evolved.
And today we know that even in low risk patients, that means patients who are very much fit for surgery, TAVR is equivalent or probably better than a surgical alternative.
So over a period of time, once the cost comes down, the valves become better, I think therapy will be offered to everybody.
With every passing day and every passing month, there is some improvement in the valve technology which helps in doing the procedure better with better long-term outcomes. So I think yes, the future is going to be exciting.